Okay, we'll call the meeting back into order. Thank you, everyone. I'd like to welcome our next investigator and all of the associated people with this next trial that we'll discuss. This is Protocol 1401-1289, Phase 1-2 Gene Transfer Trial of recombinant AAV9 MCV NAGLU for MPS IIIB. And our presenter is Dr. Kevin Flanigan from the Research Institute at Nationwide Children's Hospital. Just a little background, Dr. Flanigan is a professor of pediatrics and neurology at Ohio State University and an investigator for the Center of Gene Therapy. Dr. Flanigan received his clinical fellowship training in neuromuscular disorders at Johns Hopkins Medical Center University and in the human molecular biology and genetics at the University of Utah. Dr. Flanigan has extensive experience in translational research in DMD and related myopathic disorders, and is the principal investigator of a natural history study of MPS IIIA and B patients. Tim Miller, the CEO of the sponsor, Abeona Therapeutics, is also in attendance, as well as a number of guests who will be making comments in the public comments section, I believe. Dr. Flanigan.
Thank you very much, and thank you for the invitation to discuss our protocol. I just want to mention the key personnel on our proposal, in addition to who was already mentioned, Hien Fu and Doug McCarty, who developed the preclinical work we'll touch on, and Reed Clark from the clinical manufacturing side at Nationwide Children's is here. We're representing, in fact, a larger team from Nationwide Children's Center for Gene Therapy, groups that have brought before this committee protocols for human gene transfer trials. The rationale for our study, first of all, begins with the idea that mucopolysaccharidosis type 3B or Sanfilippo type B is a devastating disease. It's a monogenic disorder due to autosomal recessive defects in the gene encoding the enzyme NAGLU. It's relentlessly progressive and typically leads to death by the end of the second or the beginning of the third decade. And importantly, there's no treatment currently available for the disease, so there's unmet clinical need. We propose the first gene transfer trial of human NAGLU using a recombinant AAV9 vector directed at targeting the root cause of the disease. We believe we can correct the neurological and the somatic features of MPS IIIB with a single intravenous transfer, and at least we can demonstrate that we can do this in adult mice. We feel it's an ideal candidate for gene therapy because of the bystander effects of NAGLU. That is, the enzyme is partially secreted and can be taken up by neighboring cells. Only very low amounts, 1 to 10% of normal levels of enzyme activity, is needed to normalize metabolic function in bystander cells, and therefore it's not necessary to deliver the target gene to every cell in order to get optimal benefits. And we expect to take advantage of the trans-blood-brain barrier neurotropism of AV9 to restore NAGLU activity in both the central nervous system and the peripheral nervous system, as well as somatic tissues, by our approach of systemic vector delivery. There are advantages to this approach. One is the potential for one-time dosing as opposed to lifelong enzyme replacement therapies, as an example. The cassette we've proposed uses an ubiquitously active CMV promoter that has demonstrated efficiency in long-term gene expression in the CNS and in somatic tissues in multiple studies. And although this is primarily a safety and tolerability study, based upon our preclinical studies in mice and our data in non-human primates, we believe there is, in fact, a potential, at least, for yielding clinical benefit in patient subjects. Just a brief review about MPS IIIB. MPS III is a disease that's marked by normal development for the first 1 or 2 years, and around the first or second year, developmental delay becomes apparent. By age 3 to 4, severe behavioral problems begin, leading and then eventually progressive mental deterioration that progresses into severe cognitive dysfunction. In a third stage, behavioral problems slowly disappear, and motor retardation, the inability to walk, and increasing spasticity occur. And death typically occurs by the end of the second or the beginning of the third decade. I've mentioned the signs and symptoms. Some of the somatic features include a particular characteristic dysmorphism, coarsening of the face, and other features. And in fact, this is often what leads to the diagnosis in children. This is just a list. I won't go through all of these, for all of the components of what we consider the second phase of the disease and the third phase of the disease, but to point out this is one of the reasons that we're choosing a systemic delivery with AAV9 rather than intrathecal or intracranial delivery in order to be able to reach the somatic tissues as well. Sanfilippo syndrome is marked by accumulation of glycosaminoglycans in the form of heparan sulfates that accumulate within lysosomes, leading to tissue pathology. And in fact, there's four different types of enzymes that are involved, four different enzymes that are involved in this degradation process, each of which leads to a type of Sanfilippo syndrome. The diagnosis is usually done in the presence of cognitive decline in the typical features that I mentioned, by urinary GAG quantification and characterization, followed by serum or leukocyte enzyme level determinations, and then now genomic mutational analysis. And it's type B, this enzyme, which I'll call NAGLU, that we're addressing in the current study. The accumulation of lysosomal storage leads to CNS pathology. Unlike other mucopolysaccharidosis, the predominant features here are, in fact, in the CNS, and that presents a challenge for some therapies, like enzyme replacement therapies, where it's a challenge to get across the blood-brain barrier. The result of this accumulation is progressive cortical volume loss, and here's from human MPS III patients. One can see a brain of a 6-year-old patient and a brain of a 9-year-old patient. There's loss of cortical volume, and actually I won't go through all the details, but we can actually demonstrate changes in myelin, white matter components as well as by using spectroscopy. We can show a diminishing NAA to choline ratio, showing loss of neurons in tissue from children with MPS III. We are planning to make use of AAV9, which was first shown to cross the blood-brain barrier and demonstrate neurotropism by papers actually from Brian Kaspar's group at Nationwide Children's, who's developed protocols for SMN gene therapy trials, and this has been repeatedly demonstrated, including by Dr. Fu and Dr. McCarty, who are here, who first showed in MPS IIIB mice that recombinant AAV9 crosses the blood-brain barrier, allowing delivery to tissue of the brain. So just to reiterate one more time, we believe the systemic approach has advantages, specifically more widespread distribution through the vascular supply to the brain, as opposed to CSF intrathecal approaches, which have predominantly ependymal transduction, or direct intracranial injection, in which there's limitations to the amount of spread that can be achieved for a vector. And again, the simultaneous systemic delivery to somatic tissues is a feature. The preclinical data supporting this was presented in our package, and a couple comments because there was one or two questions raised about it. In mice that were 4 to 6 weeks old, these are mice that have brain pathology but do not yet have measurable behavioral deficits. A single IV injection of our proposed vector in mice that are then evaluated about 4 months after injection show correction of behaviors, and I'll show you two examples of this here. This is tested at day 4, two tests finding a platform in a Morris water maze, falling from a rotorod, and in both cases one can see that either what is our lower dose or our higher dose in this group that was tested in this younger group of patients shows correction of this behavioral activity. Here the latency to find the platform, or the latency to find fall from a rotorod. And Dr. Chatterjee, in one of her questions, asked about the fact that our lower dose and higher dose in this group seem to show the same activity. And as I'll come back to a moment later, this is not the data that we actually used to establish our minimal efficacious dose for the trial. But just to continue on with these younger mice as they were treated, we can show that delivery to these mice shows persistent global central nervous system, peripheral nervous system, and somatic transduction. Here's what we're looking at here is actually in red is the NAGLU enzyme in liver and cerebral cortex at 6 months post-injection, and then also in mice that are carried out to the end point. These mice typically die by 13 months, so we don't have a direct comparison, but these are animals living close to 2 years, and we can see in dorsal root ganglia that there's transduction of dorsal root ganglia, cortex, intestine, including myenteric plexus, and although there is some loss of NAGLU activity from the liver. We quantitate this below, and I've just highlighted with a pink box the liver. This is 6 months versus endpoint, and we can see whether at our low dose or at our high dose in the liver there is some clearance of this, likely related to the fact that liver is not postmitotic. There's turnover of liver cells. But in the brain, in fact, there's persistent expression of NAGLU, and brain being really our target tissue. We can show persistent expression of NAGLU. And corollary to this, obviously, is clearance of GAG storage. And again, here we'll look in brain, and this is again in the 4 to 6 week old mice that were treated. In this one, I'm showing you data from the higher of those two doses, and you can see that there's correction of GAG storage in animals examined at the endpoint of their life. And just a couple more slides just to emphasize what we do see in the brain. The correction of lysosomal storage pathology. Here, the red staining is for LAMP1, a lysosomal protein that marks lysosomes. The upper of these is always a non-treated mouse, and you see that there's lysyl storage in all areas of the brain, as well as hippocampus, dorsal root ganglia, liver, and heart. And in animals treated with AAV9, at the endpoint, there's significant clearage of all of these. That gives a more graphic picture, if you will, of the effects of GAG clearance. A corollary to this is the decrease in secondary neuropathology in the same mice. Here's a stain for astrocytes. We can see there's, in fact, quite a bit of astrocytosis, consistent, if you will. You can think of it as tissue of neuronal, of CNS damage in the untreated animal versus an animal carried out to endpoint with the lower of our two doses. There's significant clearance. And in fact, this is a measure of astrocytosis, that it's diminished in all of the portions of the brain, or counting neurons in the Purkinje cells in the cerebellum, for example. So there's correction of the neuropathology as well. And most importantly, that we can show that this normalizes survival. So this is survival curves from our vector treated again in the younger mouse group, at two different doses, 5 times 10 to the 12th or 1.5 times 10 to the 13th vector genomes per kilogram, as opposed to the untreated animals that die around 13 months. We can see that there is survival that's really nearly indistinguishable from wild-type animals in animals treated at either of these doses. Dr. Chatterjee, in one of her questions, pointed out that we don't see a difference between these two doses, so how does this relate to our choice of doses for the trial? And in fact, I want to point out, we actually went on to extend this a little bit to the older mice, that is, mice that are treated at 4 to 6 months of age. These are mice that not only have pathology, but already have measurable behavioral defects. And in these animals, I'm going to pick two examples here we can see a task acquisition test here in a dose of 1 times 10 to the 13th or 2 times 10 to the 13th. And we don't see correction of the task acquisition at 1 times 10 to the 13th, but we do see correction of it at 2 e to the 13th. And there's included in our packages other motor and behavioral tests that show similar features. So really, we think that the cohort of older mice more likely reflects the typical clinical situation, as patients who, by the time of diagnosis, typically have significant functional impairment. So it is our dose, so really the 4 to 6 month old treatment animals is what guides our choice of doses for the trials. And here, similarly, this is somewhat updated from what's in the original package, but shows survival curves, so that higher doses are required for survival to be corrected in mice treated at a somewhat older age. So therefore, the minimal efficacious dose that we have defined and the lowest proposed dose we are suggesting for our trial, or proposing for our trial, is 2 e to the 13th vector genomes per kilogram. One question was raised about how does this compare, for example, to heterozygotes. Well, first we should just point out that in our updated version here of Table 13, that NAGLU expression in the MPS IIIB brain is actually persistently elevated in animals. Here's our 4 to 6 week animals, our 4 to 6 month old animals. We do see NAGLU activity that remains elevated. Question was raised relating this to heterozygotes, for example, in human population. expression. And we note that NAGLU expression is at or above heterozygote level and often above wild type, supraphysiologic, in nearly all time points. But we found it really sort of difficult to predict how to compare this directly to human heterozygotes, in part because it might not be exactly relevant. That is, CNS and somatic tissues in a patient who's they have abundant storage of GAGs that have to be cleared, so higher levels may actually be necessary. But we do find no evidence that overexpression is harmful, and that was yet another question that came up in response to the reviewers. We have no evidence for abnormalities either by hematology or blood chemistry levels in mice or non-human primates. We have no evidence of toxicity, and pathologic toxicity, and enzyme replacement therapies, we would point out in similar lysosomal storage diseases, result in peak enzyme levels thousands of times above normal without consequences. So we don't think that our supraphysiologic expression will be detrimental. A question was raised about persistence of expression from the virus. And we'll begin by just noting that persistence of vector genomes in the CNS of monkeys, of non-human primates, was present at 6 months. We have two groups here, a set of older animals and then a set of younger animals treated at, in fact, our target dose. NT for both of these means animals that have received no treatment, and we see that there's quite low levels of what are perceived as vector genomes, whereas vector genomes here are actually elevated in all of the animals persistently in the brain through either 3 or 6 months of treatment in either group. And similarly, there's persistence of NAGLU expression in the CNS at 6 months in the non-human primates. What we have here for comparison is an untreated wild-type animal and the level of NAGLU activity that we would expect from that animal versus animals treated at 3 months or at 6 months with 2e to the 13th vector genomes per kilogram. And we see that there's persistent NAGLU brain activity. And in fact, I didn't draw attention to this in the other one, but each of the blue ones is the untreated animal, and there's persistent tissue expression as well. And we'll say that brain and somatic NAGLU activity remains supraphysiologic at 6 months, despite modest decreases in the peripheral serum NAGLU levels. And those are things that we included in the original submission. Finally, just to graphically show this in the brain, here we can see that persistence in the central nervous system is noted in the cerebellum, in the brainstem, in the thalamus, the hypothalamus, and this is again staining red for the NAGLU enzyme, as opposed to the untreated animal. So we do think that there's persistent expression. And we should just note that in other models, for example, in factor IX AAV therapies, there's been now studies showing long-term expression of factor IX up to, for example, 5.5 years from an AAV vector. A question was raised about autoimmunity, and we did note that the antibody responses to human NAGLU were demonstrated in non-human primates. However, there was no evidence for autoimmune pathology in any of the tissues at 6 months post-injection. And MPS IIIB mice that were, in fact, null for NAGLU did not show any evidence for clearance of transduced cells over 2 years, despite an antibody response that was seen in the mice as well. And there were no cytotoxic T lymphocyte responses by ELISpots that were generated in the non-human primates. So just to move on to our proposed trial, this is the vector, as we've mentioned. What we've proposed is a trial that includes inclusion criteria of age 2 years or older, confirmation of the diagnosis by enzyme or by genetic analysis, clinical history consistent with the disease, exclusion criteria of the inability to participate in the clinical evaluation, a medical condition that precludes lumbar puncture, the use of anesthetics, inability to be safely sedated by the anesthesiologists who are part of the study team, pre-existing antibodies to AAV9, and so forth. We have proposed 2 cohorts, 3 subjects who will receive a single infusion at the low dose of 2e to the 13th vector genomes per kilogram, Just to reiterate, this is the minimal effective dose in the older animals in the preclinical studies. Because the majority of 3B patients are diagnosed due to cognitive deficiencies, we believe these mice better model the clinical scenario. And considering the disease severity and the universally poor outcome of the disease, we really don't feel we can justify a subtherapeutic cohort in this study. If that's considered safe and non-toxic, we would propose to infuse 3 additional patients at a dose of 5 e to the 13th vector genomes per kilogram. We think it's essential to include exploration of a dose range as part of a phase 1 trial, and preclinical data supports the safety of this dose. Our outcomes will be determination of safety that's based on the development of toxicity, which we would define as a grade 3 or higher event, to be brought to the attention of the DSMB prior to approval of any additional dosing to evaluate what that event was and have agreement from the DSMB to move on. Secondary outcomes will be improved cognitive ability or stalled cognitive deterioration at 6 months after treatment. We intend to test the child using the LIDAR International Performance Assessment, a nonverbal measure of cognitive function, as well as parental ratings of adaptive functioning using the Adaptive Behavioral Assessment System, the Child Behavioral Checklist to assess emotional and behavioral problems. We'll also evaluate hepato and splenomegaly at 6 months after treatment as measured by MRI, and we'll obtain CSF and serum NAGLU enzyme activity levels. The primary outcome will be safety. Safety really assessed by absence of inflammatory response in the target tissue, assessed by lumbar puncture at 1 month, 6 months, and 12 months, with assessment for protein, glucose, cell count, and differential. One of the questions that the reviewer raised was whether all of the LPs were necessary. We feel that the 1 month one, which was specifically asked about the 30 days after infusion, is a reasonable safety measure because we do think that there will be significant expression of the recombinant protein at that point, of NAGLU at that point, and will give us an additional safety point rather than waiting 6 months out, particularly in deciding to continue to dose children. And assessments at baseline 6 and 12 months will include urinary GAG levels, hepatosplenomegaly, and the other measures that I mentioned, including the brain MRI with volumetric analysis of white and gray matter, diffusion tensor imaging, and the 1H spectroscopy that I showed an example of before. This is a summary of the study procedures. A specific question was raised regarding lumbar puncture and brain MRI in our natural history study, and it is our intent to do so as well in our gene transfer study, to perform both of these procedures under a single sedation event. And so the child is sedated by the anesthesiologist and put in the MRI machine, taken out, and as they are still sedated, an LP is performed. We'll make use of the anesthesiologist to perform a lighter degree of sedation in patients for lumbar puncture alone at 30 days when we're not obtaining an MRI scan. We consider it a sedating event, although it's certainly a less profound anesthetic event based on the anesthesiologist's choice of medications to use for the individual patient. So I'll just summarize by saying that this is a disease with a devastating impact on patients and families. No current treatment is available. We think there's significant unmet clinical need for it. We know that AAV9 has undergone now quite a bit of preclinical testing and is in fact entering clinical trials for another CNS disease at our institution at Nationwide Children's Hospital. I'll refer you to a protocol presented here as 1210-1188. And we believe that a phase 1 safety trial is certainly supported by our preclinical data. And I'll just close by acknowledging support of several foundations that are in fact represented here to speak at the public comment section and National Institutes of Health, as well as really a quite large team at Nationwide Children's Hospital that plays the critical role in bringing our translational gene therapy studies into human trials. Thank you.
Thank you, Dr. Flanigan, for a very clear and comprehensive presentation. We'll now hear from the individual RAC reviewers, their comments to you and your responses. And the first reviewer is Dr. Michael Atkins.
Yes, so Dr. So Dr. Flanigan, thank you for that presentation, and thank you for doing this work. This is, can appreciate how devastating this disease is for the families, and with understanding the biology of the disease and being able to potentially reverse the pathology with a gene transfer represents a very exciting opportunity, and your preclinical data in the mice are very exciting. I didn't have major problems with the protocol. My concern was that you be able to interpret the results adequately to be able to move forward. And so, although this is a safety study, I think understanding that a treatment is safe is probably not as meaningful if you're not giving an effective dose or getting the treatment to where you want it to go effectively, because obviously doing nothing would be safe. So you want to make sure that it's safe at a dose that is potentially effective. And that's why I had asked that I wanted to make sure that you had a good measure of what was going on in the CSF in terms of NAGLU levels, so that you could be comfortable that you could interpret them at each dose level along the way. I think you've responded to this, that you're looking at NAGLU levels in your historical perspective trial that you're doing, but I don't think you provided any data on what you're finding at NAGLU levels in the patient population, in particular how reproducible they are in an individual at a particular time point. Because if there's broad variability, you may misinterpret, with only 3 patients per arm, a natural variation for an effect, or miss an effect if by underestimating the amount of variability that you could potentially see. So if you could just respond with what you know from your natural history study about how consistent the NAGLU studies are, and to let us know that the LPs will actually be able to be interpretable.
Well, thank you. Thank you for that. That's a point that I didn't address, and one that certainly is a concern to us as well. We don't know the answer yet for reproducibility for NAGLU levels. In our natural history study, we've enrolled multiple MPS IIIA patients, and our first MPS IIIB patients are coming down shortly. But we have tested samples. The laboratory that's doing those levels for us is a clinical laboratory that's provided us assurance of the technical reproducibility from samples that they've done. We don't know about inter-patient variability. And one of the goals we have, of course, in doing a study with 2 LPs in our natural history cohort, is to determine how much variability there is. We don't expect to have significant differences for several reasons. The first is that most of the patients, not all the patients, but most of the patients have null mutations, so their levels are essentially 0. So we do expect, at least based in the animal studies, that we will see fold change greater amounts of this. So we think that individual variability for patients who are at essentially null or near null levels based on the technical performance of the assay will be interpretable if they replicate what we see in the non-human primates. We don't have a reason to suspect that there's wide variation either in serum NAGLU levels and then reflected in CSF NAGLU levels based on the mechanisms of the mutation or our understanding of the biology. And I don't expect that to be the case even in those patients who have missense mutations or not completely null mutations. So the short answer, that's the long answer. The short answer is we don't have that data yet. We anticipate having significant amounts of that data, including technical replicates of human samples from our patients' population, by the time we initiate the study. But it is a concern to us. I should say it's something we're aware of. The fact that it's probably 2 orders of magnitude less in the CSF, well, we're not quite sure with the relative relationship between CSF and serum NAGLU levels. It's something we're determining as well as part of this natural history study.
So just to reiterate, you may not, I think, with 3 patients at different dose levels, see major changes in your behavioral assays, especially in patients who may have relatively advanced disease, and you may not be able to see changes in the spleen size or the liver size. And so I think you're going to be relying on, and there may not be differences in toxicity, but you're going to be relying on the serum and the CSF NAGLU levels to potentially determine whether you've done anything
Right.
in order to go ahead. So it's not trivial to make sure that you're doing the LPs at the right time and that you have thought of how many patients you might need to actually study or how many samples you might need to study to know whether or not you've actually accomplished anything by putting people through this procedure.
Well, I appreciate this comment, and we'll keep it in mind. And can I add one other comment that you brought up in the review as well? The question was whether it might be better to do 2 baseline LPs. And we did address it in the written response, but I'll just add here to say that we can certainly perform technical replicates on individual samples to get part of the reassurance for it. It would be hard for us to justify, I think, doing an additional LP and the risk associated with it without clear potential benefit for the patient. But I appreciate your comments very much, and it's something we're giving a lot lot of thought to.
Well, the data from the natural history study should hopefully
critical.
help.
Yeah.
And maybe the serum data will reproduce what's going on in the CSF, and you can actually then rely on the serum data for choosing, determining whether you've actually established a consistent transfection with this gene that's actually functioning.
Thank you.
Okay, Dr. Chatterjee?
First of all, congratulations. I know your group has been working on this for a long time, and it's nice to see it come to the RAC. Very nice study, and as you point out, it is a devastating disease with no therapies currently. Your preclinical data looks very good, and the systemic.
Having trouble hearing.
Okay. Is this better?
Yes.
Okay. The preclinical data certainly supports the clinical protocol that you're proposing. And I think it's a very nice study, and it's definitely worth doing. I just have a few questions. For the sake of the record, I will go through the questions. You've provided answers to most of my questions. Your answers have been, spot on.
Okay.
Most of them do address exactly what I was trying to ask. And then I'll ask you maybe one or two other questions that I hadn't thought of earlier. Okay, so my first question dealt with how you decided on the 2 doses. In particular, the thing that struck me initially was that in the cognitive tests that you did in the mouse model, the lower dose actually performed, the mice receiving the lower dose of the vector performed better than the mice, a little bit better than the mice receiving the higher dose. But you explained that those mice were treated at 4 to 6 weeks, so they were younger mice. And so those mice were younger than the age at which you would identify the patients and treat them, and so that's a different scenario, and that's a reasonable answer. So 2 times 10 to the 13th vector genomes per kilo, you've shown is the minimum effective dose to treat mice that are starting at an older age of 4 to 6 months. So that is a reasonable justification for choosing that as the lower dosage. And the higher dosage, you said, was resulted in higher levels of genome copies per cell in the CNS, as well as higher levels of enzymes. So I think the justification for the 2 doses are reasonable, and even at the lower dose, you are seeing significant benefit, increase in lifespan. So I'm satisfied with that. My second question was, how do these two doses compare with heterozygotes? And Dr. Flanigan's addressed that very nicely in his talk. Although I guess the NAGLU levels are about half in the heterozygotes, and there's no difference in GAG levels between wild type and heterozygotes, but he does point out that in a patient it probably would take more than that to cure because of the accumulated store of the glycans. So it's not, you don't expect to clear a 1-to-1 ratio of therapy with the level of enzyme produced. So I guess that's why this is a clinical trial, and you'll find out from the study, which doses is the best, which of these two doses is the best. My third question had to do with the overall durability of the treatment and vector persistence. This is a question that comes up from time to time. You did see loss of vector genomes in the liver, but not in the brain. And the liver is a slowly turning over organ. What puzzled me a little bit is that other tissues, such as muscle, also do turn over slowly, but you didn't see equivalent losses in all the tissues. And I don't know if that's a factor of the rate of turnover, or if it's an immune-related phenomena. I know you did not see CTL to either AAV9, but you did see antibodies to NAGLU. So it's so I don't know whether you're getting destruction. I mean, although you have no clear evidence of immune-mediated destruction of transduced cells in the liver, could that be a possibility? Is that something you would worry about?
We saw no evidence. I'm sorry, may I just address? We didn't see evidence of pathologic change in the animal models to correlate with what would look like antibody-mediated clearance. We saw no immune filtration or similar.
And also the CTL, the ELISA was performed in both on both blood lymphocytes and lymphocytes isolated from liver at the end at the last endpoint.
Okay. And the liver has, in other studies, been shown to be somewhat tolerogenic to the transgene as well. So, so that sort of argues against immune destruction. But it's still a curious phenomenon because this is one of the first studies that actually shows that. Do you expect? I did ask whether you thought this was a function of time or a function of the lifespan of the mouse. Your non-human primate studies went out to 6 months, but do you have? I mean, I don't know if they've gone out longer. Whether you have any non-human primates that have gone out longer? Do you know?
We haven't beyond 6 months. The lifespan studies, we really have longer endpoint studies in the mouse model, as you saw, but we have no non-human primate studies beyond 6 months.
Yeah. Although this does not have that much direct bearing on MPS 3B, it probably does have relevance to other liver-based protocols. So that's why I was asking about that a little bit too.
Yeah, but in mice, in 3B mice, so the liver in 3B mice, the liver in 3B mice, liver is the only one you see significant reduction in the transduction and the genome copy numbers. But in other tissues, mostly non-dividing tissues, there at endpoint there is a slightly decrease, not in a big scale. We think it's because the aging you also have you also lose it.
Yeah.
We don't know.
Yeah. Yeah. I guess we'll have to see what happens in the clinical trial and what happens with other trials. Okay. My fourth question dealt with whether you had any idea of how much NAGLU, what levels of NAGLU would be required for therapy, and you've addressed that very appropriately. I don't have any further questions. And since in the higher dose, particularly the higher vector doses, you saw pretty high levels of NAGLU in some tissues. I asked whether it was overexpression was toxic, and it clearly is not. And then I asked whether the immune responses to NAGLU could could function as an adjuvant effect and give rise to autoimmunity. And your response was you don't have any evidence for that so far.
That's correct.
In either the mouse or the non-human primate model. And as far as preclinical models go, that's the best you can hope for. And then next is the clinical trial. And my last comment had to do with, because I expect that you probably will be treating very young children, maybe toddlers or younger, and AAV9 has very broad tropism, and AAV is shed, to be careful for not having the caregivers get transduced inadvertently. And the response to that was that you would probably go through 9 to 10 half-lives of the vector in circulation before the patient is released, and then appropriate precautions will be taken.
That's correct.
So one other question that I did have was in terms of identification of the patients, and what is the age that you expect to treat your patients at?
That's one of our goals of our natural history trial, in fact, is part of clinical trial readiness to assess the availability of subjects for this in the appropriate age range. 3A is more common than 3B in the United States. We have patients that range in age already identified as part of that ongoing trial. We've identified patients within the ages of 3 to 15, for example. We're emphasizing the younger age group in our natural history studies, but I also think that we can't directly compare those who've chosen to take part in natural history studies versus who might choose also to take part in a therapy that has some potential of benefit, even as a safety trial, as a phase 1 trial. I don't believe we'll have any trouble identifying patients in our target range between, say, 2 and 10 years old of individuals who will be for the first 6 doses. And as we mentioned in the application, if we find continued safety and see any hint of efficacy, we would return to the FDA and consider asking to treat additional cohorts, perhaps of older and more advanced children.
So the patients identified primarily by their symptoms, would you be genotyping them?
We will. In fact, most patients now have genotyping as part of their clinical evaluation, most but not all. In all of the patients enrolling our study, we're taking DNA samples in order to either, to genotype those few individuals who haven't had it, who have had diagnosis based on urinary gags and serum NAGLU alone, in order to perform genotyping in a CLIA-certified laboratory setting and so on. But we're also banking that material, and we would do so in this study as well. For this study, we would undoubtedly do mutation analysis, although we haven't stated it this way. In any individual enrolled with only enzyme level determinations, we would undoubtedly perform genotyping in the baseline period before dosing, because we would want to know that mutation as part of the study. So we would definitely do it.
Okay, so that answers pretty much all of my questions.
Okay, thank you. And the third reviewer on the phone, Dr. Faust.
Hi, can you hear me okay?
Yes.
I'm having a little trouble hearing you, so if you could maybe move your lapel mic up a little bit, that might help.
Dr. Frost, is that better?
A little bit, yeah, thank you.
Okay.
Well, I want to reiterate the previous comments about my admiration for your efforts to do something about this horrible disease, and I have no problems with the protocol itself other than some procedural questions, which I'll go through here. You're planning to do 4 lumbar punctures, and I wasn't clear what the scientific need for the one at 6 months was. You replied that you need to monitor the possible inflammatory response. But it seemed to me it would be unusual to have no inflammatory response at 1 month or at 12 months, but then to have it at 6 months. So I didn't quite get that. Or conversely, if there was inflammation at 1 month and whatever happened at 12 months, I didn't quite follow why knowing what happens at 6 months would add anything to your scientific understanding about adverse effects. So maybe you could explain that a little better to me.
Certainly. We anticipate that, based on animal studies, we anticipate sort of full expression or peak expression by 1 month. So that's a time point where we would expect to see an early inflammatory response. Given the fact that we don't know safety, that we, beyond our animal, this is first in human studies, we thought it would be reasonable to not wait 12 months out to look for any sort of ongoing inflammatory change. The disease does show progression, and it would be, I think it would be hard to be certain that any sort of progression in a patient was unrelated to CNS inflammation without an intermediate time point to assess to assess the possibility of inflammation in the CNS. So really, I just think it was prudent to add a time point between what we would expect to be an early inflammatory response and waiting out for a year where we're looking for really sort of late changes. It also gives us additional information that I think is really important on NAGLU expression in the CNS as measured in the CSF over time. We've modeled this in monkeys, in the non-human primates, as out to 6 months, as we've mentioned. But really, given that this is a first in human trial, I think we do gain additional information on the expression of this vector over time. And I would say as well, this is based in part on conversations I think with parents who have children with this illness, that most of them would consider that an acceptable risk over the course of a year to undergo that intermediate time point. That's not a quantitative measure. That's from talking to parents about it. So it's the combination of those things that we think is most prudent to include the 6 month time, the time point. Mostly because, as I mentioned, primarily if we see a lack of efficacy and a progression of disease, we don't want to misinterpret that some way as we don't want to overlook the possibility that there's some sort of immune mechanism responsible for that.
Well, I'm still not quite sure I grasped it, but I don't want to belabor it, so I won't press it any further. It just seems to me if there's inflammation at 6 months and it's gone at 12 months, I'm not sure what it adds to know whether it's there at 6 months or how severe. But so I don't quite follow it, but I'll move on. Second, that you are going to have a data safety monitoring board. I suggested having somebody with background in research ethics on that, as is increasingly common with data monitoring committees. You said there's an ethicist on the IRB. That's not the same. The DSMB goes into much more detail, obviously, than the IRB does on the primary data, and then draws a conclusion, yes or no, continue or not, but the IRB doesn't get to do evaluation. So it seems to me it's increasingly part of the DSMBs. It would be desirable, but certainly not essential, so I'll leave it at that. Third were issues about the consent form. These come up with virtually all phase 1 studies that are presented to the RAC. You use the word treatment, which seems to suggest there's a known benefit, and you agreed with that, and you said, I gather you're deleting that and calling it, quote, potential therapy, end quote. And then in another paragraph, you say that the main purpose of the study is to learn about the safety of the new product, which is obviously correct, and that the clinical benefit is unknown and unlikely. I'm sorry, I'd suggest that you put in the first paragraph that clinical benefit is unknown and unlikely. And you seem to disagree with that. I gather you think clinical benefit is likely. Obviously, you would, as you point out, there would be no point in doing the study if there wasn't the potential for benefit and if you didn't expect benefit. And it would be illegal to do it under the common rule, and I agree with all of that. So there's always the possibility of benefit, otherwise you wouldn't have put all the tremendous amount of work you've done that goes into this. But everybody has that optimism about phase 1 studies, and 95% of the time they don't pan out, probably worse ratio than that for gene therapy. So that optimism and hope is always there, and it's appropriate. But it seems to me it's statistically unlikely that therapeutic benefit will follow a phase 1 study. It's just very, very unusual. So I'll stop and get your reaction to that as to why you think this disease or this therapy is more likely to succeed than not, or more likely than the hundreds of other gene therapy protocols that have been done.
Well, Dr. Faust, I appreciate your comments, and I respectfully disagree with some component of them. That is, I don't think it's necessarily fair to compare, or relevant to compare, this phase 1 trial to all other phase 1 trials of gene therapy. Phase 1 trials of, to take an example from our own institution, of a phase 1 trial of delivery of a microdystrophin into, or a sarcoglycan gene into a muscle of the foot, absolutely is unlikely to have a clinical benefit. The difference here, I think, is that in our animal model and how we've targeted it, we think that that there is some potential of benefit. It's not a relevant comparison to all phase 1 trials. I think, too, we lose the ability, I think we truly want to maintain our clinical equipoise on this, and that is to say we simply do not know whether this will have benefit. We've made the dosing decisions based on what we think is the best likelihood of having some therapeutic benefit. I think it removes our equipoise to say we don't think this is going to work. Actually, what we're saying is we are going to be testing safety, and we simply don't know and can't say whether it'll have some benefit to the patients.
Well, I certainly agree that we don't know, and I certainly agree there might be benefit. I think we're just talking about the likelihood of it. Everybody who does this kind of research highly expects there's going to be benefit. No one would spend the kind of time, money, resources, and energy and so on unless one had an extremely high degree of hope and expectation of benefit. It's just that it virtually very seldom turns out that way. So I don't disagree that there might be benefit and that should be said. There's a possibility of benefit, but it's been standard on virtually all protocols that I've reviewed in my 4 years on the RAC to use the language I suggested. There's extensive discussion and analysis of this on a website. I understand you had trouble accessing it, and maybe the staff can help you with that. But that NIH document strongly recommends language more like I suggested. You referred to another protocol on the agenda earlier today as having language similar to yours, and that's correct about the protocol as submitted, but at the review earlier today it was changed with the agreement of the investigator. So I'll leave it at that and see what others on the committee think. Next comment was page 2. This is also, I think, related to the benefit. No, it says on page 2 on the consent form under why are we doing this research study, you made some comments about the mechanics of how this might work if it were succeeded, and how they succeeded in the animal studies, and it seemed to imply more knowledge and optimism about how it's going to work in humans at this time, and you responded that you have modified that language accordingly. I haven't seen the modified language, but I'll accept your word for that. Fourth was a question about whether there was anesthesia for this 6-month lumbar puncture that we discussed, since that one is not accompanying an MRI, which requires anesthesia, and you've answered that you would be needing to use appropriate sedation for children with this condition. Comment number 5 was about the benefit section. It's about the issue that we talked about, so I won't rehearse it again. 6 is another recurring problem, which is the long list of people that you want the patients to agree to have identifiable information, such as the IRB, OHRP, the Data Monitoring Committee, the FDA. I've been on an IRB for 37 years, chair for 31 years. I've reviewed 20,000 protocols. I've never yet seen an instance in which identifiable information was needed by any of those people. And I understand your institution is asking you to put that in, but I would respectfully suggest you provide some pushback to your institution and suggest to them there is no need for those organizations to have identifiable information. Finally was the issue of use of stored samples and data for future research, in which you offered the participants or their parents two options, namely yes or no, and I suggested a third, which is to that they might be interested in future studies but would want to be contacted. You said it would be impractical because the samples would be de-identified, but I went back to the protocol and it looked to me like it's not clear that the samples would be de-identified at that stage, that they could or they could not be based on the participants' preferences. So it seemed to me you could ask somewhere along the way after your primary research is done whether they want their samples stored, and whether, if so, whether they want them identified or de-identified. Obviously, if they're de-identified, they can't be recontacted, and there's virtually no ethical issue to use those samples without consent. But if they choose to have them retained in an identified way, then it seems to me it would be fairly simple to recontact them. It's a small number of participants.
I take your point, and we'll be happy to revisit that issue in response to these comments.
Okay, thank you.
Okay, thank you, Dr. Foss. Do other RAC members have comments or questions? Dr. Hemsgold.
So first, I want to join the others in commending you on a very important and timely protocol for a very devastating disease. And really applaud you for that. But I wanted to ask you about the potential for integration. I know there have been some studies out there that suggest that in some studies there have been a random integration in nuclear genomes and also in mitochondrial DNA. And I'm not familiar enough with AAV9 to know whether you would expect that, or if you would be looking at. You said you would collect DNA, so that would be an easy thing for you to look at. So I was just wondering whether you were considering that.
I comment that I think AAV9 will be as likely to integrate as any other AAV vector. It's really a function of the genome contained within the package that's going to drive integration. Mm-hmm. We don't have any particular reason to believe that integration in this population would be different from any other population. The only data that we have in terms of adverse outcomes from potential integration would be in the mouse model, where in several animals we have seen tumors, but we had the same incidence of tumors in treated MPS 3B animals as we did in untreated wild-type animals. So we don't think that we're driving excess tumors with this vector. When we checked those tumors for integrated genomes, they were negative.
So are you planning to look for it? Because it's, I mean, I'm not saying it would have adverse effects, but even if it doesn't, it might be interesting to know. I was just adding kind of to the bulk of information about the AAV vectors, and it might be something that would be relatively easy to do if you have the DNA.
Certainly, I think that all of our greatest concern would be in the liver, and we will be doing liver evaluation by MRI at several time points after the injection. I think vigilance will be our just in terms of potential tumors, would be our best pathway here. I don't think that we have a way of accessing the liver in terms of testing for integration of the vector directly.
My other question is a little bit more complicated. If I got this right, your total enrollment is an N of 6, and you were saying in the protocol that individuals enrolled will be at least 2 years of age. But you were indicating when you were talking about it that they could be between 2 and 10 years of age maybe. So I was just wondering whether you have contemplated or at all concerned about that children 2 years of age are quite different from 10 years of age, and if you have an N of 6, it might be difficult to kind of gauge what the safe dose is, just because of those reasons.
Right. I've left that intentionally somewhat open-ended in large part because we think that our natural history data will help to guide us for how useful these measurable outcomes are across a range of ages. It may be when we come actually with that data in hand and think about an IND submission, we are limiting to a younger age group. For example, there's no question, for example, the cognitive measures will be easier and more reliable in that group, but other ones, parental reported outcomes, may in fact be uniformly changing over time.
I mean, you're talking about outcomes, but this is primarily
for
a
safety. I
study.
apologize. Right.
So the safety there might actually be some differences whether you administer a vector to a 2-year-old versus a 10-year-old.
That's very true. I think it's likely at present we haven't limited that upper dose, but that's something we really will keep in mind as we think about the
that's
final.
The power of statistics.
Right.
You know, have an N of 6.
Right. Thank you for that comment.
Dr. Atkins?
Yes, I was just going to follow up on Dr. Frost's question about the 6-month LP, and thinking about the NAGLU levels again. If there were high NAGLU levels in the CSF at 1 month and absent at 12 months, would you ever envision a situation where you would give repeat dosing in the future and use an intermediate value to help to decide whether the time frame or the time interval for intermediate or for repeat dosing?
Well, the first question is just to address the feasibility of repeat dosing, which in any AAV trial we have to admit up front is a challenge, or recognize up front as a challenge. That is, the antibody responses generated from dosing in the first place are going to be a challenge for repeat dosing. But I should say that our researchers from our own institute have published data now on the use of, for example, plasmapheresis in non-human primates immediately before dosing antibody-positive animals in a different model and a different reporter gene, but in fact have shown that there is a route to redosing therapy. We believe that may, we believe that may provide a route to redosing therapy for AAVs, mediated therapies in humans. It's a reasonable point that you brought up, and I hadn't thought about that. Could we identify an inflection point on a curve for NAGLU levels that might steer us toward redosing? I suppose that's a possibility. Your scenario does bring up a point for us, though. If we have a 1-month time point with high expression and a 12-month time point with no expression or low expression, we really don't have a curve. We have a curve defined by only 2 points, which is we would like more information out of this sort of precious cohort of patients to understand how this behaves in the CNS. Whether it'll guide dosing is a little premature for us to say, I would say.
Dr. Dresser?
On this, excuse me, on this point of clinical benefit, the ethical issue is, you know, you have the parents of children with this horrible disease, and they're, just from the material we got, they're very optimistic and hopeful, and so the concern is we don't want to promote unrealistic hope. So I wonder if you'd be willing to say something like, it is unusual for participants in an early safety study like this to benefit.
I think that's a very nice compromise, and one that we'd be acceptable with doing. I think that we'd be happy to adapt some wording like that. And I think that's. I thank you for that suggestion. I'd be happy to do something.
Could you repeat that, Rebecca? I didn't hear it. The language you suggested.
It is unusual for participants in an early safety study like this to benefit.
I think that's fine.
Okay.
Thank you.
I appreciate that suggestion. Thank you. I'm going to write it down. It comes out in the minutes, I know, but
It'll be in the minutes.
okay. Thank you.
Any other questions from RAC members?
Just, of course, as an ethicist, I weigh in on that one too. It's a continual problem for us. But I did want to say that this introduction to your consent form was really excellent, and we usually tell you everything that's wrong. But I wanted to say those first 2 paragraphs were clear. They explained what a gene was and what you were trying to do there, and in a way that it's often rare for us to see as clear explanations.
Well, thank you very much for that comment. Our team, I think reflects, I wish it could reflect on me, but it reflects on our team, some of the people I mentioned to you before who really help with the documentation and preparing these, with reviewing them and so forth. So, but thank you for that comment. I'll share with them too.
Dr. Chatterjee?
I just have one quick question. What is the frequency of the disease, and how difficult would it be to accrue the 6 patients?
I don't think it'll be, the frequency is quite low, and I apologize. I should have had the figure, and I'm going to, I believe it's in some population surveys at 0.5 per 100,000, but I would like to check on that. I should know it offhand, and I apologize that I don't have that at my fingertips. I don't think it will be difficult to accrue 6 patients for a trial like this. We know of cohorts of, we know of patients and patient organizations like those represented here who are recognized newly diagnosed patients each year, several newly diagnosed patients each year. I think 6 patients is quite realistic to perform in the time frame we're talking about for this trial.
Any questions from any other RAC members on the phone?
Just, was there any reason why you had to be 2 years old, since the diagnosis is often made far earlier?
The diagnosis is actually not often, in our experience, is not made far earlier. It's generally made at the point of time when, by the age of 2, when there's a decline and beginning of loss of motor functions.
The consent form says 1 to 4. And some of the other protocols say between 1 and 4. I'm just wondering.
I apologize. That's our error in the consent form. We thought that was a realistic thing to pick up most patients by the time of diagnosis, and when they can also do some of the motor testing that we ask of them as well.
So I have 2 questions. One of them relates to the experience from the hemophilia studies with using AAV, where some of the patients seem to have an immune response to vector components about 5-6 weeks out, and seem to be losing the effect, and now intervention with steroids seems to possibly stabilize that. The time points that you're looking at might be bracketing around that, not looking at that time. So I think there's a 1 month and a 3 month time point. A lot of these, and it's a different serotype, which may affect the time course, but it might be useful to monitor liver functions and some other signs more frequently in the early months, to see if you can detect, if that occurs, an immune response to virus-containing cells, to know it, and then maybe possibly to intervene in future patients. So you might want to look at your time.
Okay, well, I appreciate that comment. We can certainly do that.
And the other one is actually as much for you as for the foundation members who are here, and that what's the status of newborn screening? And just my experience, I treat patients with SCID, and newborn screening has started in the last few years, state by state, and it's revolutionizing the way we see the patient. So instead of having babies coming with severe infections, which would be the equivalent of your patients presenting symptomatically, we're finding the patient in the first few weeks of life and intervening much earlier with a hypothesis that the outcomes will be better. So where does newborn screening stand for this and the other MPS diseases?
Newborn screening is not in common usage. It's not done for these disorders. So it's really still in the diagnosis is by clinicians at the time of symptom presentation.
Is it technically possible?
Hyen would like to answer that, I think.
There are several groups, actually international efforts, trying to make some of these MPS disorders available for newborn screening, available for some of the disorders based on if the therapy is available. For example, some of the MPS 1, MPS 2, and MPS 6, there's already enzyme replacement therapy. I think that those guys will come through earlier. I think the method used is a blood spot, dry blood spot for enzyme activity assays. I think if this is going through, therefore newborn screening will follow, because there's no therapy available, so there's no point to do it again.
And so just the experience in SCID was that it was mandated or recommended at the federal level, but newborn screening is done state by state, so it's still very much the confederacy of states that do, and so it comes on state by state. So it really calls for an advocacy activity at sort of the state level to bring it along, when, as you said, when there's an effective therapy. Any other questions from any RAC members? If not, then we are open to comments by members of the public. I think some people came to speak. And so when you speak, could you first identify your name and if you represent an organization? Thank you.
Hello. Our names are Sue and Brad Wilson. We're from Western Springs, Illinois. We represent the Children's Medical Research Foundation and our daughter, Kirby Wilson, afflicted with Sanfilippo. A telephone call changed our lives. After giving me the devastating diagnosis on Kirby, I was told by our doctor nothing could be done. We should enjoy her while we have her. She's the same little girl she was yesterday. And the person we were told to call, representing a support group, told us doctors didn't care, buy a cage to contain her. We chose to challenge that doctor and that person, challenge our daughter's fate, form a foundation, which was the first of its kind for Sanfilippo, and raise funds for science, a cure for Kirby. And no, Kirby was not the same little girl she was yesterday. She was our almost 4-year-old daughter that was about to define fortitude and show us what facing adversities with grace was all about. So with her little hand in ours, we set out on our journey, our hearts filled with hope for her future. Since that time, almost 19 years ago to the day, we've devoted our lives to provide Kirby with the best opportunities possible. Our focus has always been her abilities, not her disabilities. Kirby's mission was song, dance, and happiness. Happiness for all around her. Her smile was infectious, and she asked just one thing of others. Happy? Mommy happy? Kirby's happy. Her words, now lost, will live in our hearts forever. Her message to find happiness in each day is something we strive to live by. Without words, she still speaks volumes. Our foundation has granted over $3.7 million towards a cure. In 1997, it was our good fortune to meet Dr. Haiyan Fu and fund the initiation of this work. Today, Brad and I stand before you not to ask you to solve our problems or take away our daughter's pain. We are simply asking you to allow Nationwide to take this work to trial, to see it through to a successful conclusion. Hope will not keep our daughter and others like her alive. A therapy will. You spoke today of risks to patients. I think all of our children afflicted with this devastating disease are indisputable proof of what doing nothing is. And we thank you very much for your consideration.
Thank you.
Good afternoon, and thank you very much for allowing us to be here to share with you today. My name's Elizabeth Linton. My husband and I, Randall, have traveled from Toronto, Canada, to share our story about our life with our daughter Alyssa and our passion for finding a treatment for Sanfilippo syndrome. Almost 16 years ago, our youngest daughter Alyssa was diagnosed with Sanfilippo syndrome at the age of 4. She was a bright, vibrant young girl, full of life and potential, and full of dreams. Doctors at the Toronto's Hospital for Sick Children told us of Alyssa's fate. They told us to take her home and enjoy her every day, because there is no treatment to stop her regression. There is nothing to treat her symptoms because there is no research in Canada, very little happening in the world, and that was because there was no money for research. Soon after that, we connected with Brad and Sue Wilson, who just spoke. They inspired us with what they were doing in the United States by starting a foundation to raise awareness. We went back to Canada and we started a charity called the Sanfilippo Children's Research Foundation back in Canada. So with faith and determination, we have committed ourselves and everything about us to doing everything we could do to save our dear daughter Alyssa and change the fate for other families with children diagnosed with Sanfilippo syndrome and change the state of research in this world. I left my career and I started this foundation with my husband and have dedicated my life for the last 15 years to raising funds to support research out of the basement of our home, at the same time as caring for Alyssa's every changing need and raising our 2 other children to adulthood. We are a true grassroots charity in Canada, the only one in Canada supporting research in the world. The SCRF is run solely by volunteer efforts, where 96 cents of every dollar raised has been committed to research. We have raised almost $5 million to date. This may not seem a lot in the scheme of research and the cost and the money that goes into it, but I mention this only because it has supported 32 research projects around the world, and over $1 million of these dollars has been committed to supporting the research efforts of the amazing team of doctors at Nationwide Children's Hospital. Because their work shows the most promise of moving closer to a treatment, we trust in Alyssa's lifetime. It shows more promise than any other research project that we have been involved with globally. What a legacy her life is going to leave. Raising funds has not come easy at all. It has meant many sacrifices for our family and many involved with us. It has involved a lot of prayers, blood, sweat, and tears over the years. We're not a large national charity at all or a pharmaceutical company with a lot of funds to contribute. We're just a family with an amazing community of people around us who are determined and committed to making a difference in this world, to finding a treatment for Sanfilippo syndrome, moving research forward so our children that are afflicted with this horrific disease will have a future, especially those that are yet to be born. Over recent years, a number of family foundations and fundraising efforts have been born in the U.S. and around the world because of the hope that has blossomed from the research efforts at Nationwide Children's Hospital, and a few of these families are represented here today. We have dedicated our lives to getting research to the point that it's at today. We are asking you now to help us with this vital research and allowing it to continue to move forward from here to the next level with a decision to allow these gene therapy clinical trials to happen. We see promise, we see potential, and we see hope in the work that is presented at Nationwide. Your decision today will not only impact the lives of Sanfilippo children and their families in the U.S., but those around the world, including our daughter Alyssa. We thank you in advance for working with us today, because tomorrow may be too late for our children. Thank you for your time.
Hello, and thank you for allowing me to speak here today. My name is Kara O'Neill. I've been a practicing pediatrician for the past 10 years. I'm an assistant professor at the University of South Carolina, where I care for children with special health care needs. I'm also mom to my beautiful daughter, Eliza, who's 4 years old. She was just diagnosed this past July with Sanfilippo syndrome. I just want to speak very briefly on the unique risks that Sanfilippo families tolerate when looking at clinical trials, and specifically with this proposed clinical trial. First, let me say that as parents, we would not put our children in a situation to assume risks that are greater than the potential direct benefit offered by a treatment. simply because their condition is terminal. However, it cannot be ignored that our children do have a fatal disease with no available treatments. It is also necessary to consider the rapidly progressive and disabling course of this disease when weighing how much preclinical data is enough data. Critical activities of daily living, such as speech, mobility, swallowing, can be lost in as short as a 3 to 6 month time span. As a community, we have educated ourselves on the science at hand. We accept the risks inherent in this gene therapy protocol. These risks are far outweighed by the possibility and potential of direct benefit to Sanfilippo children. The science is ready, the families are ready, and these children deserve a chance at life. Thank you so much.
Thank you. Thank you for letting us participate today. My name is Stuart Seidman. My wife Jennifer is here with me. We represent the Sanfilippo Research Foundation and our son Benjamin. Benjamin, unlike many other children, was diagnosed at 18 months of age. In a week's time, our family will celebrate his 18th birthday. 5 weeks ago, Benjamin left us. He's not going to be here to celebrate. In that intervening period, we watched him lose skills, mobility, speech, cognitive capacity, but never the joy, the laughter, and the inspiration he brought our life. Also during that intervening time, we funded Dr. Fu and Dr. McCarty's research for over a decade. Our scientific advisory board reviewed many proposals of many other protocols. This is one that we continue to fund over that time. It became apparent in Ben's life that there was a period where he would not benefit from this work, even if it went forward and were successful. But we still were here. We still continued our efforts. Benjamin is not with us. We're still here, and we still continue our efforts.
Because we believe in this research.
And we believe that it's an inspiration from our children, all of our children, and the children that are yet to be diagnosed, and Benjamin's brother and sister who are carriers and need to think about their future, that this research be continued and allowed to move forward. Thank you for your time.
Well, thank you all very much it's always sobering and educational to us to know what it's about. Most of us are physicians or scientists or ethicists and deal with these things, but each personal story makes it so much more real. So thank you. I know it takes courage to get up and speak in front of a committee. It does for me. So any other comment before we have our session to go to our recommendations? Okay, so we'll take about a 5-10 minute break to go to our recommendations, then we'll reconvene. Okay, we'll resume session. We're waiting for Dr. Zoloff to come back, but oh, there she is. We can't proceed without you. So I will read back our recommendation letter, and then we'll have discussions by both the RAC members and the presenters if you have any comments on ours. And there's one point at least we want your input on to make sure we understand what was said. So the first comment related to the protocol is your protocol states that successful gene transfer will be demonstrated by NAGLU expression in the CSF, and this will be used as a criterion along with safety to expand enrollment into the highest dose cohort. You do not yet know whether there is variability in the levels of NAGLU in the CSF of these patients, and you only propose to treat 6 patients before making this decision, or maybe it's 3. It may be important to consider whether this sample size can provide an accurate signal of efficacy, is defined by NAGLU expression in the CSF. In addition, it is difficult to say the intervention is safe without documenting an increase in NAGLU expression due to the gene transfer. Consider whether it is feasible to primarily enroll patients with close to undetectable levels of CSF NAGLU. And the question is, would 3B patients all have basically undetectable levels?
Yes, we can select patients with null mutations who have essentially undetectable levels, yeah.
Okay. So consider selecting such patients so you'll be able to reliably assess that the gene transfer results in expression of NAGLU in the CSF. The natural history study may also inform this question. Our second recommendation is, in previous trials using AAV and hemophilia, immune responses to the vector in the liver were detected by a rise in liver enzymes that occurred sometimes at 5 to 8 weeks after dosing. These trials have used steroids to address this complication with continued transgene expression. Your trial proposes blood tests at 1 month and 3 months could potentially miss such a reaction if it occurs between 4 and 12 weeks. While this is a different serotype of AAV that you're using than was used in the hemophilia trial, consider adding liver enzyme blood tests at more frequent intervals early after dosing.
We'll be happy to do that.
And the two ethical comments are, the first, which we've discussed, the informed consent addresses the issue of use of research samples for future research and currently offers two options: to allow samples to be stored and used for research purposes in the future, or to refuse to store the sample and allow them to be used. A third option to consider is to give subjects the option of having their samples be stored in an identifiable manner and be contacted and give specific consent for the studies on these samples at a later date.
Okay.
And the last point is, while certainly you've put together an impressive preclinical package, we share your hope that this approach will offer benefit to these children, it is an unfortunate reality that most phase 1 studies do not lead to an efficacious therapy. To minimize the risk of overpromising the potential of this first-in-human trial, consider revising the benefit sections to state, quote, "It is unusual for participants in an early safety study to benefit," end quote.
We will be happy to accommodate all of those requests.
Okay. Any comments by RAC members?
Just again, just to thank the parents and grandparents for coming today.
Anyone on the phone with a comment?
No.
Okay.
None by me.
Any further comments by the investigators on the recommendations?
No, we'd like to thank you very much for your thorough and very helpful review of our protocol. Thank you.
Okay, then we will vote whether we approve these recommendations for the protocol. Dr. Keem.
Keem, yes.
Atkins, yes.
Sadlin, yes.
Koch, yes.
Dresser, yes.
Chatterjee, yes.
Cohn, yes.
Sarzotti also yes.
Zoloth, yes.
Hammarskjöld, yes.
Ornelas, yes.
Curry, yes.
Cannon, yes.
And on the phone?
Whitley, yes. Faust, yes.
Polisky, yes.
Dr. Kai, are you still with us? No, okay. Okay, well, thank you all very much for coming and presenting today, and best of luck with the study.
Thank you.